Hi, everybody. We're going to get started so we can hopefully finish on time. Welcome to another session on lung transplantation. I'm Kevin Robinson from the University of Pittsburgh. Don, do you want to introduce yourself?
Hello, everyone. I'm Don Hayes from Cincinnati Children's Hospital.
And we have the privilege to have a third co-chair with us today, Dylan Mortimer, who's actually going to start off the session. He is a person with cystic fibrosis and has undergone a lung transplantation and is going to tell us about his experience with that. Guts, glitter, and glory, right? Yeah. So let's start. So first we have the NACFC presentation disclaimer, and then Don and I both have some funding from the CF Foundation, the NIH, but no other relationships to disclose. And with that, I'll hand the podium over to Don.
Hey, everybody. How we doing on Saturday morning? Everybody ready to get home, or we got a little energy left in us? Hopefully. Yeah, I heard that one. All right. 3 of us are ready to go. So I have CF, and I have received a lung transplant, and then I received a lung transplant again. So 2 double lung transplants, born in 1979, diagnosed in 1979, fought off transplant till 37, and then was transplanted again at 39 years old. And I just turned 45 this week. So I'm really, all right. There's that energy. I knew y'all had it. And I'm blessed to be here, but I'm blessed to be alive at all and breathing anywhere, as you all well know. So the research that I do and always have done and always will do is in visual art. I went to art school for college. I went to grad school in New York for art. And so, this is my research. I love hearing about all so many of you are doing in medical research, biological, and so for me, I throw paint and, glitter around and sculpture, and I investigate that way. Never made, though I was trained as an artist, came up as an artist, never made any artwork about my health until I was listed for transplant the first time. And that was my moment, common story, CF patient, didn't want everybody to know, didn't want pity, didn't want it to be all about that. But when I was listed, it felt dishonest to not bring it in some way. So I swung the pendulum hard, completely the other way, and leaned into transforming all these symbols that for me have been chaotic, traumatic, and difficult to become gleaming, glorious, beautiful, shiny objects of hope. So a lot of mediums involved in the work that I do, but the primary one would be the medium of glitter. It's dirty, it gets everywhere. You may know, you may have kids, you may have glitter in, I probably have glitter on my face right now. It spreads everywhere just like disease does, right? And we hate it, and it's messy, and it's dirty, and yet it is beautiful. Disease is obviously not beautiful, but the transformation we see in stories like mine are addicting. Right? We love these stories of hope and seeing people overcome. And so I can't quite stop using glitter as this metaphor of transformation. So this was the first piece that I created in regard to my health. And the title is I Want More Air with exclamation points. And it is about 4 feet by 8 feet sculpture with kind of a mixed media, cut foam, corrugated plastic, cardboard, lights in there, and tons of glitter. So I was trying to, take an image of a bronchial tree and do this sort of surrealistic, add bronchial branches, this declaration for me of hope. I want to not just survive, I want to thrive. I want to have more air than I can possibly take in. And so it's kind of sparked for me the beginning of this, taking imagery that has been, again, important to me and flipping it. So in my search initially, kind of image searching around this conversation, I'm searching for words like air and maximum air and all this stuff, and Air Jordans pop up. The very shoes I've coveted since my youth. And it dawned on me that there's air inside them. So I've been striving and trying to get a hold of these shoes all my life, just like I've been trying to get a hold of air all my life. And so they became for me, again, this flip symbol of, as they would be for anyone, athletics or fashion, whatever the case might be, life for me. And so here's this double lung. So I was creating this work and I was listed for transplant now. Again, I'm just flipping all the symbols and imagery, scars, cells, IV poles, and transforming them. So this, the work kind of evolved to be more in painting. And so this is 4 feet by 32 inches, and it's called Try Not to Panic. So there's my kind of only slightly exaggerated version of an IV pole with the various medications on there. Again, adorned and bathed in this glittery, hopefully beauty. This is a forest. Again, every time I use trees in my work, I'm thinking about bronchial trees and their transformation. So here, this forest of interconnected bronchial branches have this kind of health reigning on them, this healthy, sparkly DNA, these imagined healthy cells. This is 4 by 8 feet, so I'm showing you some large pieces. And then as I was nearing this surgery, I created a vision of the transplant surgery. So here's me kind of laid out, being operated on, and all these sort of cells flowing in, flowing out, however you may see it. The doctors operating around me have halos that are like the cellular forms. And so there's this sort of interplay of faith and health and all these things. People are praying, people are operating. There's just all of it is happening. And I'm wearing Air Jordans on the operating table, which they didn't really let me do, but in my imagination, this is how it went. So this was the next exhibition where this installation was kind of on the wall of a gallery. 12 feet high, 52 feet long, of interconnected bronchial trees, which, as you can see, phlegm dripping from the bronchial branches, as I later realized, was like a literal, perhaps subconscious rendition of an airway clearance treatment where all of my youth, I was turned upside down, bronchial tree upside down, and phlegm, hopefully, flowing off of the bronchial branches, right? So this is routed like from a digital file cut aluminum that is layered in here. So there's kind of layers of colors. And this is now placed at University of Kansas Hospital. So I love to place artwork in medical centers, especially where do people more need hope and inspiration and dignity. And where is often the art worse than medical centers, hospitals? And I mean, it's, prisons maybe, I don't like, as a patient being wheeled through and walking through whatever endless blank walls and stock art. It's, I love that science increasingly points to people heal faster, more effectively, last longer, and less expensively when they are surrounded by beauty and uplifting environments that have dignity. So, this is my message. That was me at the opening. On about 25% lung function. And so, created this large piece with the help of others and got out of the hospital to go to the show, went right back in the hospital, being listed for lung transplant. And this is me a few months later, transplanted in 2017 with, they have you walk pretty soon after, and there's me carrying all my stuff, all my medical equipment and cords. The people assisting are not helping me carry any of that. They're making sure I don't fall. So, this is the path. After about 3 months of rehab, I felt amazing, felt the best I'd ever felt in my life. My lung function went from 25 to 105 at its height. This lasted for about a year and a half. And we moved back to New York City with my family. So I'm married for 19 years now, have 2 kids that are now 15 and 13. They were 5 and 7 at this time. We all moved back to New York City. And because of antibody rejection, my lungs function goes from 95% in June to 10% in November. So from I can run 5 miles to I can't climb a flight of stairs, in a city where it's nothing but stairs everywhere you look. So it was nightmarish and dramatic, and all the while, this is the next piece that is kind of in process between my 2 transplants, where about 40 artists from around the world were invited to do a project in this park. And my idea was to take a dead or dying tree and paint it pink like a bronchial tree and revive it with glowing pink glitter, much like my lungs were revived from death. So we did that, unbeknownst to us, in sealing the moisture by painting the tree. The moisture was sent up to the tips of the tree, and we literally brought it back to life. So now, thank you. So now it's, that was completely intentional. We planned this from the beginning, to just bringing trees back to life, no problem. But I knew to be a metaphor also, there's a story within the story of like, the original tree we planned wasn't going to work. The city was worried about it falling. And so I'm like, okay, do we need to pare it back a little bit more? They're like, we cut it down. And so I'm like, what? So I'm watching this tree be cut down as I'm getting the phone call about rejection. And the city is going, you're going to have to find another tree. You're going to have to find another tree. And so I'm going, this is now my situation. I got to find another bronchial tree, which we did in a miraculous story that to try to put all this inside 1 minute was I'm screening out 71% of potential matches to me because of antibodies. So in New York, they're saying you will never be transplanted here. You got to go to Duke. That's your only chance. So we have an evaluation set at Duke, and I get a call from a woman from Instagram who follows me, I've never met, who knew my story. Her cousin had passed, family talk. They wanted to donate his lungs to me. I said, that's so sweet of you. Thanks for thinking of me. I'm sorry for your loss. That's not how this works. There's a list, there's a protocol. She had not checked to see if it's a match of any kind. She just called. So we hang up and I put it out of my mind completely. Don't tell my wife or family, none of that. And my doctor calls me the next day from New York and says, this woman called and has lungs for you. And I said, first of all, that's something you can do. and she goes, I've never heard of it, but yeah, you can do deceased willed donations. And I go, and it's a match? And she goes, yes, long story short, does have 2 of the antibodies we've been trying to screen, not the main ones. So initially my wife and I were like, well, there's no way we can do it. And she goes, well, hang on. We've all consulted in New York and concur with St. Louis, where the first transplant was. We all concur you should take these lungs. And I say, why? And she goes, 1, we don't know if you get another chance. And 2, this is how she said it. We have some research around retransplanted lungs, but not a lot. So we have some ideas on what we think will work, but we don't really know. So I go, do we have some time to think about this? And she goes, yeah, you got a half an hour. So we think about it for half an hour, but do go ahead and proceed. They fly a doctor from New York to Kansas City where the lungs were. They look good. They come back, tell me to be up at Columbia by 1 in the morning. They'll know by 5, and I'm there. I get a call at 4:45 in the morning. The lungs are here and they look good. We're taking you back right now. And within 7 minutes, I'm out, 7 hours of surgery. Everything goes well. I wake up. All these surgeons are around me going, you're doing great. Now, what happened? Instagram, like, how did this happen? So back to this piece now. This is installation in Salina, Kansas, of 55 feet of glowing, shining, healthy cells called from the scars to the stars. So how do you put that story to words? Like my research and my life ambition is to try to invoke the joy and the hope in an almost like aggressive, assaulting way, right? Large, big, shiny, lots of glitter to transform the situation that seemed very hopeless in 1979 to now. And I do it with this glowing, evocative artwork. Here's backs of ambulances transformed because all of these symbols to me ride this tension of we wish nobody had to deal with any of this. And yet how beautiful, all these things have saved me. I'm alive because of them. Every IV pole, every scar, every ambulance, and here's the final one I have. We live in LA now, and I'm in this reality where I'm making artwork outside in 70-degree weather. From all the trauma I've been through, I'm like, what dimension have I stepped through? What portal am I in to now receive this joy that is almost too much for my heart to take? Which this is life, isn't it? Like we hold immense, immense, immense trauma and immense, immense, immense joy. And so here, like the imagination of the surgery happening in this like exotic paradise, this feels like my life. How do you collide these things? So this is the work that I do. There just happens to be at the Beatrice booth in the exhibition hall, a 16-foot by 8-foot rendition of a piece similar to this with firework exploding DNA and scars and cells. So if you get a chance to go check that out. Thank you for having me. I am so blessed to be alive. It's so good to be here with you. And what a joy we have to be alive, right? Every breath is really a gift.
I'm sure everyone has lots of questions for Dylan, but we are going to hold the questions for you until the end, if that's okay, so we can move on. So it's my pleasure to introduce our next speaker, Dr. Ramos from the University of Washington, who's going to talk about lung transplant referral guidelines for people with CF.
Thank you very much for inviting me to be here today to speak, and also for your inspirational talk, because this is exactly why we do this, is so that people can get the benefit of transplant and live long, happy lives.
Amen.
Yes. So I'm going to talk today about the lung transplant referral guidelines for individuals with cystic fibrosis. And I have no conflicts related to this presentation, but I have some grant funding, and Vertex has given me travel support and honoraria. So I want to give you some context for what was in our mind when we were working on the initial lung transplant referral guidelines. Survival with low lung function can be prolonged, and back in 2017, we published work from the CF Foundation Patient Registry with data between 2003 and 2013, and found that the median survival after an FEV1 less than 30% of predicted was 6.6 years. Now, this figure from the paper shows the number of people with each outcome on the y-axis, and on the x-axis, it's the time since they reached an FEV1 less than 30% of predicted. And what you can see is that more people died each year after reaching the FEV1 less than 30% than underwent lung transplant. And so the blue bars are people who died without transplant, and the red bars are the people who were lung transplanted. And it's about 10% per year were dying, and only 6 to 8% were undergoing lung transplant. And so when you think about the ratio of lung transplants to death, we were underwater, we're less than 1, and we really want to have more transplants compared to the deaths. Also, people with CF and lower socioeconomic status, Hispanic ethnicity, and/or minoritized race have lower rates of referral for transplant, listing for transplant, and lower rates of undergoing the transplant operation, while they have higher rates of death without transplant. And for people with Medicaid insurance, they have a 2 times higher risk of death without transplant, and people with Hispanic ethnicity with CF have a 3 times higher rate of death without transplant. And in the ETI era, white, non-Hispanic people with CF have experienced most of the benefit related to the dramatic reductions in rates of lung transplant. So this is one of the main figures and main take-home messages from the 2019 CFF lung transplant referral guidelines. And so to walk you through it, the squiggly line was the FEV1 trajectory at the time. You saw it every year in the CFF patient registry data report. And on the y-axis, we have some FEV1 thresholds that we think are important. And we said, for all people with CF, we we think you should have routine discussions about disease trajectory and lung transplant as a potential component of clinical care down the road. So talk about it so that it's destigmatized and we know that it's a treatment option. But once somebody has an FEV1 less than 50% of predicted, we should really start having annual discussions about lung transplant with a focus on addressing potential barriers to transplant. And if when someone reaches the FEV1 threshold of 40% of predicted, we should start screening for markers of increased disease severity and look for things like hypoxia, hypercarbia, pulmonary hypertension that's developed. And if these markers of increased disease severity are present, then you should refer them to a transplant program so they can be further evaluated and assessed for whether it's time to consider lung transplant. And when their FEV1 reaches 30% of predicted, we recommended referring all individuals to a transplant program. And the reason was early referral is an attempt to avoid emergent transplant or missed opportunities for transplant. More people were dying without a transplant than undergoing a transplant operation. And so in the presence of contraindications, we recommended discussing with at least 2 transplant centers prior to determining that an individual is not a transplant candidate, because we may not realize in the CF centers that the practices evolve, and what used to be a contraindication may no longer be a contraindication to transplant. But the guidelines were written and published before the ETI era. And now when you look at the registry, you can see that the trajectory is not exactly the same as it used to be for FEV1 over time, and perhaps things have started to stabilize. And we know that the FEV1 percent predicted for 18-year-olds has also improved. So when patients transitioned from pediatric to adult in 2002, the median lung function, or FEV1, was around 73% of predicted. And these days it's normal, and less than 1% of adults, less than 1% of 18-year-olds have advanced CF lung disease. So when we think about how effective has ETI been in the advanced CF lung disease population, people with FEV1 less than 40% of predicted were excluded from the phase 3 clinical trials of CFTR modulators. Case series for people with advanced CF who are clinically prescribed ETI show improved FEV1, removal from the lung transplant waiting list, and fewer deaths or lung transplants. And in the US CFF patient registry, death and lung transplant have decreased by 72% and 85% respectively compared to pre-ETI. And I want to walk you through this figure from a new publication that's in press by one of our pulmonary fellows at University of Washington, Tiana Milinek. There's been a dramatic decline in CF lung transplants in the US. And on the y-axis on the left, you can see the number of people with their first time lung transplant for CF. And across the x-axis, you can see each year over time. The little blue boxes have the number of lung transplants in each of those years that are for CF in the entire United States. The right-sided y-axis shows the proportion of the total transplants in the United States that were for people with CF, and that's the orange line. And so between 2011 and 2018, CF made up about 10 to 12% of transplants in the United States. ETI was approved in the US in October of 2019, and there was a dramatic decline in the number of transplants for CF. And in 2022, there were 39 transplants for CF, making up 1% of the US transplant, the proportion of the US transplants. But that ratio of the first-time lung transplants to deaths that I talked about on the first slide decreased in 2022 to 0.55. So there were 2 deaths for every 1 transplant that happened. And previously it had increased, it had improved. In 2014, it was 0.67. More deaths than transplants, but in 2019 it was 1.26. There were finally more transplants than deaths in the United States for people with CF. And in 2022, half of the lung transplants and 70% of the deaths were among people on ETI. So some people with CF can still benefit from lung transplant. People who had advanced lung disease when they started ETI, people who are unable to take ETI due to the side effects, or those with variants that do not qualify for ETI. Some people with complex medical or social circumstances, and then people with progression of their CF lung disease despite optimal medical therapy. And so we know that support from healthcare professionals, family, people who've previously received a lung transplant, and close friends play an important role while people with CF are awaiting lung transplant. And education about transplant can improve knowledge, preparedness, and transplant-seeking behaviors. The use of more adaptive framing to describe post-transplant complications can reduce anxiety. The things that happen after transplant as complications are often manageable, treatable things like infections, or even rejection is treatable. And so taking away and demystifying some of those post-transplant complications can help with anxiety. And then people with CF prefer to avoid transplant discussions during a crisis. So having the conversation earlier is certainly welcome, rather than their lung function declines, they're in a crisis, and now we start talking about transplant. So we tried to get some perspectives of CF physicians in the United States, and we did a survey of CF center directors through email, and then in person, we nagged everyone at last year's NACFC to please fill out our survey. And there were 110 responses to the survey, with a 47% response rate among the adult physicians. And physicians thought that early conversations about transplant were more useful for those who are not on ETI. And I'll call your attention to this section here. About 2/3 said that having a discussion about transplant when the FEV1 reaches 50% of predicted is very useful. 2/3 of the physicians said that for people not on ETI, and only about 1/3 said that it's very useful for people who are on highly effective modulator therapy. We asked, are CF physicians delaying transplant referral for those who already meet CFF criteria, the referral criteria? And among people with an FEV1 less than 30%, 24% of the respondents said, yes, we're delaying referral even when they meet the criteria. And between 30 and 40%, 61% of the respondents said, yes, we're delaying referral in that group too. And pediatricians were more likely to report feeling unsure about whether ETI has led to delayed referrals. And that's mostly because pediatric patients aren't often meeting the criteria for getting referred these days. And 77% of adult physicians reported delaying referral for people who met the criteria in that 30 to 40% range. So these are hot off the presses data from the 2023 CFF Patient Registry Report. And I'll call your attention to the far right column. In 2023, there were 1,985 people who had an advanced lung disease form completed in the CFF Patient Registry. And of those individuals, less than a quarter of them had the recommended testing of an echocardiogram, a blood gas, or a 6-minute walk test. And only about 39% had any one of those items completed. And so the question is, are we missing data for tests that are being performed, or are we not performing these guideline recommended testing? So this is the referral status by FEV1 category for people who have advanced lung disease forms in the CFF Patient Registry. And I'll call your attention to that less than 30% group, because in the guidelines, we recommended all of these patients should be referred for lung transplant. And what you'll see here is that a small proportion, 3.8%, received a transplant, and about 47% were referred for transplant. But half of the patients, the 32.8% plus 16.3%, were not referred. So half of people are not being referred, and 16% were not referred, and there was no transplant discussion this year. And so when you look at the reasons why people with advanced lung disease are not referred for transplant, 62.8% said had the reason chosen that there's perceived clinical stability. They're too stable to get referred for transplant. But almost 20% indicated that it's the patient's desire to not pursue lung transplant that led them to not be referred for transplant. And so there's this idea that some people on our research team are starting to coin, Melissa Basile, for one, says ETI limbo. We're talking to patients, people with CF who are in a clinical trial of a lung transplant education website. And at the end, they're talking about how before ETI, they underwent the lung transplant assessment. They'd been either evaluated or even on the waiting list, but now they have fewer symptoms on ETI, but they're still impaired. They still don't feel well. And they understand that they can live longer with a low lung function and they're not sick enough for lung transplant, but there's this unclear timeline for when transplant will be needed. And it's a really difficult situation to live in, to be in this ETI limbo. And so I just want to conclude by thinking about what do we need for updating the CFF referral guidelines. I think there are CFF patient registry data, as well as qualitative data, and then some understanding of what the CF and lung transplant teams need to collaborate on. And so from the CF patient registry, I think we could understand who undergoes lung transplant in the ETI era, which people are dying without lung transplant, and why. Are CF clinicians performing the recommended tests in advanced CF lung disease, and do these tests inform referrals? And can we develop a new prognostic model to identify people at the highest risk of death or lung transplant in the ETI era? And are outcomes after lung transplant changing in the face of an aging CF population? Some qualitative data: are people with CF open to lung transplant discussions despite ETI? How do we educate people with CF and their caregivers about transplant? And how do CF clinicians discuss transplant? Is it different for pediatricians or adult providers? And I alluded to the fact that we have a randomized clinical trial going on right now. It's Lung Transplant Ready CF2 and Caring CF, looking at a lot of these questions. And then finally, CF and lung transplant team collaborations. How do we thread the needle to avoid the stress, the cost, the time wasted with an unnecessary referral, but also avoid missing the window for transplant? How do we determine the timing of listing, going beyond transplant referral, thinking about when do we actually do the transplant? And where do we refer people with CF in the setting of reduced CF lung transplant volumes? How do we ensure appropriate post-transplant CF shared care? So in conclusion, there are far fewer lung transplants for CF. Physicians are delaying referral. Some people with CF are in ETI limbo. The guidelines were designed to avoid missing transplant opportunities, but referral recommendations seem to be too early for some people with CF who are on ETI. And revision of the CFF referral guidelines requires more data, but I think those data exist. And so we're targeting 2026 for revision of the lung transplant referral guidelines. So I want to acknowledge the CFF, the CF Lung Transplant Consortium, collaborators, mentees, and others who are moving the field forward, and the NIH and CFF for funding. And the CF Foundation Patient Registry is so critical for us to answer these important questions.
Outstanding talk. Thank you for all of that important work. For the ones that are in ETI limbo, is there any more stratification of the data related to why that 20%, I think you said, they have personal reasons why they're not wanting to pursue transplant? Is there any more breakdown of that data? Just interested in that population.
Yeah, so I think that the 20% who have declined to pursue transplant, it's partially the same feeling that physicians are having, that I'm too stable to go to transplant now. And we'd hear people talk about how symptomatic they were before they started Trikafta, before they started ETI, and now they feel poorly, but not as badly as they did before they were on ETI. And so I think there's this sense that I have time, I can wait until I feel worse. But there are things that happen acutely, and as we all know, sometimes it takes a while to find a good match for transplant. And so threading that needle of getting people there early enough so they can learn about transplant and have an opportunity, but not adding stress and unnecessary time and burden by doing it too early. And patients are trying to figure out what's the right timing. Physicians are trying to figure it out. shared decision making.
Chris Bennett from Boston Children's. Hi, Kathy. Excellent talk as always. Look, I mean, Dawn and I just last week had a call because we're trying to, to write for the first time referral guidelines for pediatric lung transplant candidates for the ISHLT. I mean, you've been on the 2021 referral guidelines, and we're exactly in this limbo. And we were really struggling a bit. I mean, before I relocated from Zurich to Boston, I mean, the last child that underwent, under my guidance, lung transplantation for CF in Switzerland was in 2018. And so from that point of view, we are really struggling because our guidelines, obviously, ISHLT is an international organization. So we have also different perspectives because there are some countries in the world where there is ETI not available. I've just been to the ERS in Vienna where a lady got up from Guatemala and said, we don't have ETI. So we need to bear this in mind. And then obviously that we have some CF centers and they are not lung transplant centers. So and we don't want to miss opportunities. But then in particular in children, obviously we don't want to miss too early. So we were really discussing, controversially, if we should actually get rid of this cutoff of and just focusing on the FEV1 only, because it's probably not just a good marker. It's just one piece of the puzzle. And exactly, we should probably assess more the severity of disease, looking for, right heart failure and these kind of issues and 6-minute walk. So really struggling. And, maybe Don wants to add to that discussion, but we haven't yet found a good, phrase for that. Also, we don't want to be politically incorrect and just waving away the 2021 ISHT guidelines. So it's really a struggle. And I think hopefully more data will help us, Don. I don't know if you want to add to that.
Well, Dr. Bennett and I are in the black hole of pediatrics because, I think it's a little bit, even though it's not well defined in adults, it's even more nebulous in children at this point, to be frank about it. But it's some of that wording. And us as a group with the ISHLT are struggling because we're from different parts of the world trying to figure this out together. Not just here, kind of US centric. We're thinking of the entire globe rather than just us in the United States.
Yeah, and I think FEV1 is still a very important piece of the equation. Yeah. But the ISHLT documents since the 1990s have said there are other factors you have to consider besides FEV1. Nobody's saying that it's just your FEV1 that makes it so that you need to be referred or listed. And I think that listing piece is the harder one. And exactly. How do you risk stratify people with a low FEV1? Because in 2013, that data I presented on the first slide, people were already living 6.6 years median survival after having an FEV1 less than 30%. It's probably 10 years on ETI. It might be longer that you could live with a low FEV1. And so you don't want to take away 10 years, but at the same time, what's your quality of life if you're living at an FEV1 of 21% for a very long time? So.
Yeah, for the first time in 2015, I put in the ISHT guidelines those things we actually said for children. So, the chance of 50% of dying within 2 years, poor quality of life, and obviously a pediatric consent as well. So these were the 3 things we wanted to have in there. But as you said, already the data before that were just well beyond. And now with the ETI, everyone is even more, confused and in the limbo. And then looking at the global picture, we're even more in it. So. Definitely. Looking forward to more data, and we're trying to solve this with some good wording, but we obviously don't want to harm as well, That's our big, intention.
Yeah, it's a balance.
Hi, Leah Cohen, UT Southwestern. So Dr. Ramos, you mentioned the Hispanic population and their decreased access to not only ETI, but to transplant. And in our population in Texas, we're seeing that where our programs are, our own center does not accept Medicaid patients. And so we are struggling with our patients who transition, who have low lung function, who already aren't candidates for ETI, helping them have the same access to transplant. And I was wondering if you have any ideas or could expand on that, on how we can pressure that, because it's also a lot for those patients to then, so our local center, San Antonio, and for people who don't know Texas, that's a 5-hour drive. So not only are you're basically having to relocate your life to then transplant, and that's already on Medicaid, already with the other disadvantages. And so I just think it'd be nice to expand the offer of transplant to all people with CF.
Yeah, I think the structural barriers that exist to getting equitable access to transplant is a key important thing for us to attack as a community. And I think that it also comes from advocacy and policy making. It's not just on the doctor side. It's us advocating to our legislators and hospitals as well. But there's not an easy answer to that one, unfortunately.
So I apologize, but I think we're going to have to cut you guys off, and Dr. Ramos will be here afterwards to answer any more questions you have.
Yeah, we'll have plenty of time after the session.
Thank you very much for the invitation to present our work. And this is the changing transplant landscape in the era of ETIs. And we'll probably follow what Catherine has mentioned and probably showing us the problems that are ahead of us with this new population. So I'm presenting on behalf of the adult cystic fibrosis from St. Michael's Hospital in Toronto and the Toronto Lung Transplant Program. I don't have any disclosures. And as a background, really what I can tell you is what you have heard all over and over again during this conference, and is that the lung transplant were increasing until 2020, and the ETI really changed completely this landscape. And then we saw a great decrease in the number of transplants and patients removed from the possibility of transplant over the years. And they are really, really less transplant all over the world. And the patients are surviving longer with advanced lung disease. And this is the French study from Martin that really illustrates clearly how these patients that were started on Trikafta delayed so much the transplant, and they were actually removed from the transplant list. So just to walk you briefly over that, he took these 65 individuals that were started on ETI, who were lung transplant candidates at the time of the initiation. 17 of them were already listed for lung transplant. 48 were considered to come into the transplant list in the next 3 months. They followed these patients for a year completely. And the result really was that one patient was transplanted 5 days after they were started on ETI. I guess it was too early to really reject transplant and know what would happen. One patient was transplanted 11 days after, but then we had remaining 63 patients on the transplant list, or the almost ready to be listed. And what we saw was that over the next months, the patients really have less exacerbations, they increase BMI, they had less need for antibiotics. And as you see, every month, patients were removed from that possibility and the transplant list. So at the end of the year, there were only 2 patients who remained in the transplant list. So they were probably just very sick and needed a transplant anyway. But this really illustrates the population that over time had been removed from that possibility of transplant. So this all, of course, opens a complete different population that we are really dealing with, and landscape is changing on that. So the genotype profile is changing, the racial background is changing. We have fewer lung transplants, as we have mentioned. We have more repeated lung transplant for those patients who have already received lung transplant and they were not in ETI. They are living longer. Our patients are living longer and with really advanced lung disease, but at the same time, they are older, facing plenty of comorbidities, other diseases, mental health, etc. So that really shows to us that the worst outcomes are known in some genotypes. So you know the study from Clausen in 2022, where they can identify there are some genotypes that will have worse possibility of graft failure. We do know the worst outcomes in non-white people, and specifically Hispanic people will have worse outcomes. Worse survival in retransplant. We know the higher risk of complications post-retransplant, and I'm sure you went through that. And then we have worse outcomes in patients who come to us with comorbidities. So in the past, we will see the patients coming with new infections, and we will just have to deal probably with new different fungal infections, different bacteria. Now we see the patients not only coming with new infections, but also comorbidities that we were not really dealing with them before, cardiovascular complications, etc. So this is really completely changing the landscape of our patients coming to transplant. And we wanted to illustrate this with 2 examples here. On your left side, you see a 41-year-old female is not eligible for ETI. They have asthma on treatment with biologic medications, has multi-resistant pseudomonas, has recurrent pancreatitis and multiple pancreatic stents due to that, pulmonary embolisms on anticoagulation, membranous glomerulonephritis with an FEV1 of only 30% and recurrent admissions. So I'm sure many of you have these patients already. But we also have on the right side a 41-year-old male who on ETI, pancreatic sufficient, with the same chronic infection with Pseudomonas, but his BMI is 45.7, and probably that increases the risk of all the other comorbidities that this patient is having: cystic fibrosis-related diabetes, stage 3 chronic kidney disease, obstructive sleep apnea on CPAP, and of course high blood pressure, and probably all the cardiovascular complications that are ahead of this. So the reality is we do deal with older, more complex and new comorbidities, even in patients with or without ETI. So that is what we are really seeing in our lung transplant population. So what is clear is that what we know today about lung transplant and the outcomes, including survival, may not apply to people that we have in this era, comparing with the patients that we had in the past. So what we are telling our patients today was based on what we saw in patients really 30 years ago even. That is completely different. So what is important is that we need to really get accurate and updated statistics so that we can provide our patients with completely different possibilities and make them to really have an informed decision based on more realistic expectations and prognosis. So that is what we really need to know. So briefly, this study objective was to describe the characteristics and clinical outcomes of lung transplant recipients in both the pre and post-ETI era. So this was a retrospective cohort study, and the time period was between 2019, pre-ETI era, we called that in Toronto, and then 2021 to 2023, the post-ETI era. We didn't include 2020 because the program was closed for some time, and we didn't really have many patients on ETI in Toronto. Then we didn't have that approved. So this included all the CF patients that were followed at the adult cystic fibrosis clinic that came to transplant, and we followed them for the first admission for their transplant, and we excluded the retransplants. So the data came from the pre-transplant Canadian Cystic Fibrosis Registry, and of course CHART review, where we identified mainly the characteristics during the previous year and all the comorbidities. Post-transplant, we extracted from the Toronto Lung Transplant database, and the outcomes were assessed from the date of the transplant to the date of the discharge. The mortality was assessed as up to 1 year post-transplant. So many of these analyses really is just a descriptive presentation, and the Kaplan-Meier method was used to estimate the probability of survival only. So this is what we see. So on your left side, the pre-ETI and the post-ETI era on your right side. So we had 19 patients in the 2019, and the other 2 years we have 8 patients. The median age was very similar, 29 and 30 years of age. We did have 75% of female on the post-ETI era. 84% of the patients had delta FIO8 on 2019, and there were not individuals that had delta FIO8 at all in the second cohort. And again, none of them were on ETI. So what we can see based on the pre-transplant risk factors, so the pre-ETI era, again, independently of being on those medications, 35% of them will be on steroids compared with 58 on the late era. And in terms of cystic fibrosis-related diabetes, 35 and 88, and cystic fibrosis-related diabetes, 58 in the 2019 and 75% in the second era. So again, higher comorbidities. Race that was non-white, 25% in the second era, so really 20% more. So when we look at the post-transplant outcomes, this really was different. So the hospital stay was very similar, the median time. ICU days were 3 and 5 respectively, and days ventilated were 2, slightly more, 3.5 on the second era. But when we look at early peri-operative complications, the need of tracheostomy was only 5% in 2019, compared with 38% on the second era. 50% of our patients had to go back to the OR for complications, comparing with the previous era that was 0%. And dialysis and ECMO days were definitely higher in the second era. So again, coming back to illustrate that the complications are more, and the comorbidities and high risks of complications are there for the second era. When we look at the survival and the probability at being alive at 6 months, in the pre-ETI era was 94.7%, and on the second era was 57.1%. So again, just as a result of what we have said. So what are the strengths of limitations of this very small study? We have to recognize the strengths are we have a very detailed and granular data of our patients. The data pre and post-transplant course, we have a really good database on that. It is a large center where we definitely will probably have more volumes to be able to look at the future. And the limitations is that this sample is a very small one. We are really on preliminary evaluation of the results, but the trends identified are really something that we just need to keep in mind for our future. And of course, it's a single center study. We cannot really generalize this yet. So in conclusion, again, fewer primary transplants, and we do have trends towards more comorbidities, particularly asthma and the use of oral steroids prior to transplant, increased complexity in the peri-transplant period, worse survival following lung transplantation. So minimizing, we really feel and hope that minimizing pre-transplant modifiable risk factors will be important to optimize the post-transplant outcomes in these kind of new patients that we will be facing. We definitely need larger study and hopefully a global effort to better understand the risk with lung transplantation in these different communities, so that patients can really make an informed decision about what is today, comparing again with what we used to tell our patients 15, 20 years ago. We used to tell our patients, you are so young, you are full of things that are going to make you the perfect person to do extremely well post-transplant. And that definitely is not the case now, and we will probably need to change and really adjust according to the new results. So thank you very much on behalf of the St. Michael's Adult CF program and all of our members, the Toronto Lung Transplant Program, and the Cystic Fibrosis Canada. Thank you very much.
So also remember, you can put your questions in online if you'd like, and we'll keep track.
If you're nervous about speaking in public, we're happy to take questions up here. That's a striking difference in the post-ETI era of how severe they are post-transplant. Has that modified how you're discussing referrals to Toronto General from the CF population? Just to, it was remarkable.
Yeah, well, I think that is really what is showing us that we need to change what we used to say to our patients. As I said, I definitely, and I still really feel, as Dylan was saying to us, we need to show this as a real hope. Transplant continues being a hope. And I don't think anyone will really not offer that, knowing that we could run into complications because there is not any other option. So we just need to really work in how we can make this better. But at the same time, at the moment that I'm offering transplant, I need to be very, very clear about the pros, the cons, and real way to really try to help them now and in the future. Kathleen.
Dr. Ramos.
Thank you for your talk and for highlighting important things that we need to keep thinking about when it comes to prognostication and post-transplant survival. With 8 people in the second group, obviously, it's statistically unstable. If one person was stuck on ECMO for 40 days, I just worry that if we change our framing too much, then it'll make transplant even more scary and stigmatized. And so I would advocate that we do have a global effort and say, what are the new era outcomes looking like? I wonder if you could comment on why none of the people in 2021 to 2023 were on ETI. In the US, 50% of our transplants in the last year were on ETI.
Well, in Canada, we didn't have that approved, so that was delayed for our patients, and fortunately, we have that now. But also in 2020, we didn't have really many transplants. The program did close, and I think that the impact of the previous year was amazing. We actually saw retransplants on the previous year. In many were retransplant. We didn't have like really first transplant for some time. So I think that probably makes a lot of difference. We were just starting maybe some of the ETI in some people that will qualify for certain reasons, but it was not approved in Canada by then.
Do you think that people are avoiding sending their people who are on ETI to transplant? Do you think there's more hesitation in Canada for doing it?
I would say that everyone probably is going to what you mentioned. Is this the right time when we should send it? I consider there are so many Canadian centers. Even before, we know that there were patients that were never referred to transplant. And I guess it's just because their physician at that time thought that maybe they were not going to qualify. I think that there is more awareness. I don't know to what extent maybe that will impact also that limbo that you mentioned, and people will be really thinking, when should we proceed? We leave it in our patients. I remember for some patients that they were really resisting to move forward and make the decision to go into the transplant list because they were hopeful that that moment will come and their life will be changed with the ETI. And we didn't have it available yet. So I think that even the patient will be more resistant to move forward to transplant because of that hope that maybe we have this now. Maybe we will get something else that will change us more and we'll have more hope to prolong life before transplant. So transplant continues being a scary maybe a moment to approach, as you mentioned. I always have also tried to show that transplant, I hate to hear when people say, like, we're changing one disease to the other. I don't think we can present the transplant as that. I think transplant is a real hope. I don't really hesitate to really say it's a real hope. We see the results as we see it on you. And that is what really should maintain us to try to really continue doing what we are doing, but at the same time, be honest when we get to the moment that we just need to do it. And yes, when we started working with the QI and the transplant, we do recognize transplant should be just one of those treatments in the list, as when you have coronary disease, you have bypass as the last one, but you don't want to ignore it. It's part of the list, so we include it always, and transplant should be just present as a hope, and don't overdo when it's not needed, but we need to really always come to that as the great hope.
Thank you.
Thank you.
Thank you. That was a great talk. I was interested that you pointed out increased use of corticosteroids pre-transplant. Do you think that's a true increased incidence of asthma overlap, or are we just last-ditch efforts? What are your thoughts on that?
I guess it could be a combination of maybe problems. One could be asthma. Many patients we have maybe with AVPA that we didn't have maybe so many in the past. So those patients do require very prolonged steroids, and what we see on those patients is such a big impact on their muscle dysfunction. And those patients, we do know the post-transplant recovery is really difficult for them. So they do have incapacity to go back to 100% where they were because of the pre-steroid administered before transplant, but also maybe the weakness they deal with, the impact of the other medications. So those patients do, I am sure they never get to the 100% where they were at some point. Thank you very much.
Yeah, thank you.
Thank you.
I get to introduce the next speaker, Mr. Andrew Potter from Cincinnati Children's Hospital.
Thank you for the invitation to speak today. I don't have any disclosures. I'm going to talk to you about acute cell rejection, cell-mediated rejection in lung transplant, and the risk that confers for later allograft dysfunction. This has been studied quite a bit in the adult population, but we wanted to look at this more. Don's group wanted to look at this more in the pediatric population. So this was a retrospective cohort study which was conducted with two groups of patients. They were under 18 years of age. One group had ACR, one did not have ACR during the first year post-transplant. These were followed in this retrospective cohort study over time. You can see the survival significantly decreased if you have ACR within the first year. So it is a significant risk factor for allograft dysfunction in the adult and pediatric population. However, the mechanisms which cause it to be a risk for allograft dysfunction and chronic lung allograft dysfunction later on really aren't well understood. So we wanted to conduct a more basic study to understand the molecular mechanisms of allograft dysfunction as they relate to early acute cell rejection, cell-mediated rejection. We know that lung transplant recipients have the highest rates of rejection and mortality compared to all other organ transplants. We think that this is partly because the lungs are exposed to the outside air, they're exposed to pathogens. In fact, if you develop ACR within the first year post-transplant, you're 3 to 4 times more likely to develop BOS stage 2 or 3 bronchiolitis obliterans syndrome. But the treatment for ACR has really remained unchanged, and it's really high-dose glucocorticoids, and there's no real molecular therapies for ACR to reduce the risk of lung allograft dysfunction later on. So this is a significant unmet need, we believe, and there's just a knowledge gap in the pathobiology of ACR. So what we set out to do was do single-cell RNA sequencing on fresh transbronchial lung biopsies, which actually Don collects. There's part of the biopsy will go to research and pathology, and part will go to research and myself. And I perform the dissociation and generate the single-cell suspension, which is then loaded into the 10x chromium instrument. These were patients who had mild ACR A2, HHLT grade A2, or surveillance biopsies from patients who had resolved ACR or never ACR. They actually never had ACR before. And we just performed the dissociation on ice using cold active protease. Previous research we conducted has shown that if you do the dissociation at 37 degrees with where the cellular machinery is active, it can activate stress and immediate response genes up to 1,000-fold, which can cause artifact gene expression changes. So we just did the dissociation on ice. So this was our cohort. This was 7 patients, some with multiple biopsies, and we had 2 patients who had ACR. We had, and then after the ACR, we call that resolved. For the resolved cohort, they had anywhere from about 30 days to about 264 days post that episode of ACR, since that last ACR episode. The age range was anywhere from 13 to 41 years old at the time of transplant. And these were sampled anywhere from 1 month to up to 8 years post-transplant. This was actually a unique cohort with patients 3 and 4 because not only did these patients not have ACR at the time of biopsy, but they didn't go on to develop ACR later. So these have actually never had ACR, patients 3 and 4, multiple biopsies. So we have these samples that we processed, and we have individual data sets which we remove doublets. We have a bioinformatic pipeline where we remove doublets, ambient RNA using algorithms. And then we integrated these together using CRAT canonical correlation analysis and for clustering. And then we also did reference mapping to help identify cell types using historical data sets, including Krasnow's cell atlas and also Tabula sapiens. We also performed iterative clustering on the lymphoid cell population to help define the distinct cell clusters. So these were a mix of different chemistries. Our methodology evolved over time, but we have about 48,000 cells in the data set, 8,000 cells for A2, and then 16,000 for never ACR, and then 23,000 for resolved ACR. So we were able to identify cells from each of the compartments in the lung. We think, a representative cell population. The fibroblast and stromal population was somewhat underrepresented, we believe. But we were able to capture cell types from all cell compartments in the lung, including mucosal-associated invariant T cells, T regulatory cells, and the lymphoid population. Also several fibroblast populations as well, even though they were a bit underrepresented. So jumping right into the analysis, these are actually looking at the differential gene expression changes which were shared in multiple clusters between ACR and never ACR, and also resolved ACR and never ACR. So these were genes which were up in 10 or more clusters in the single cell data, and also validated by bulk RNA sequencing later on. So you can see some of the pathways which were represented, included antigen processing and protein ubiquitination and proteasome degradation. These could be important for antigen processing and presentation. TGF beta was something that popped up as well. TGF beta signaling. TGF beta 1 was up in over 10 clusters. This is already a validated target in IPF and other fibrotic lung processes. Brain-derived neurotrophic factor is also been studied as it relates to fibrosis in the brain, but also can relate to fibrosis in other organs as well, we believe. TGF beta 1, other genes which were EID2 and STUB1 were also in that pathway as well. T and B cell receptor signaling also came up as well. Looking over on the right hand side, this is cell chat information flow analysis. So looking at the relative information flow and between never ACR, resolved ACR, and mild ACR, we can see some of the pathways which have come up recurrently and we focused on include type 2 interferon signaling, TGF beta signaling, VEGF signaling, and also TNF as well, the TNF inflammatory pathway. Looking at these pathways specifically, in mild ACR and resolved ACR, you can see from these circle plots that these were significantly increased TGF beta in ACR and resolved as well. Looking at the width of the line, you can see the relative information flow between the different cell groups. And some of the cell populations which had increased TGF beta signaling include basal cells, fibroblast cells, mast cells, macrophages, platelets, and megakaryocytes as well. TNF inflammatory signaling was also increased, and that was mostly as it relates to the B cell compartment. The B cell has significantly increased TNF alpha production. VEGF signaling was also increased, and this was mostly related to the endothelial cells. We saw in our ACR data significantly increased expression of VEGF receptor in the endothelial cells, including FLT1, KDR, and also increased expression of some of the VEGF ligands, including VEGF-A and VEGF-B, particularly in the immune cell populations. Type 2 interferon, as I mentioned, was also increased. You can see this is mostly relating to several immune cell populations producing more interferon gamma, including exhausted T cells, proliferating NKT cells, and T follicular helper cells, actually. Looking at this violin plot, with the stacked violin plot, you can actually see the differential cell expression a little bit better. And the individual cell clusters, you can see, as I mentioned, interferon gamma is mostly up in those specific cell clusters. VEGF-B was widely upregulated, and particularly in immune cell clusters, including some innate and adaptive immune cell clusters. And TGF-beta 1 was significantly increased in several cell clusters. You can see the blue is the never ACR, and the green is mild ACR, and the orange is the resolved ACR there. And you can see TNF was mostly relating to increased expression in B cells. But there were several genes which were up in these were widely upregulated genes. CD81 is a tetraspanin, may be critical for immune cell trafficking. GNAS was actually an activator of STAT3, a component of the JAK-STAT pathway. ALRF, ALYREF, and TMAM238 may relate to immune infiltration, and NF-kappa beta 1 is downstream in the TNF pathway. We also performed bulk RNA sequencing to help validate our single cell data. This was actually several groups. So we had the never ACR. These were from patient biopsies, frozen biopsies, not single cell. So the never ACR group, and then we had a retransplanted. These were from one patient who was actually retransplanted. They had ACR prior to retransplant, but not after retransplant. So you can see many of these genes appear to be upregulated even after retransplanting when they had a previous ACR episode before retransplanting. And then we had a patient also who had resolved ACR. So this is just looking at the heat map. You can see the hotter genes are increased, and these are many of the genes which were also increased in the single cell data as well. And I would like to thank my mentor, Don Hayes, and also Dr. Ziadi, who will be giving a talk as well, and Catherine in the pathology core, who helped enable the studies, and also our core facilities at Children's, and the patient volunteers, and the funding by the Heart Institute as well. And I'd be happy to take any questions.
I can sort of give a summary of the work that we're doing. Andrew presented the data. There's a change of the cell gene expression from the time of the initial transplant to the episode of acute cellular rejection, and then after treatment with systemic steroids. So the graft doesn't actually return back to what it was prior to. And so that's some of the work that we're addressing and trying to figure out. Trying to maybe potentially develop new therapies targeting acute cellular rejection, since most of the research in the world of lung transplant focuses on CLAD or chronic lung allograft dysfunction. So, but as we do this, we may have found a link between the two because they have been associated with each other for quite some time. We just don't have a reason why.
So, John from Boston, really interesting work, really exciting. And as someone who does clinical transplant and takes tiny transbronchs and also does single cell RNA-seq, I'm really impressed with the results you guys got.
Thank you.
In your differential flow analysis, it seemed like PDL was the most upregulated in the mild ACR.
Yeah.
I think that's something that's maybe been seen in heart transplant rejection before.
Oh, really?
And
Yeah.
I don't know, in my head seems maybe a bit counterintuitive. Do you have thoughts on that pathway being up?
Yeah, no, we see increased T cell exhaustion with the PDL1 pathway. So it's something we've seen in the ACR group particularly, maybe related to immune activation, but it is something I think worth looking into as well, because you're right, it was I think the most significantly upregulated in the ACR. So it's definitely something we should probably look at more.
Really cool stuff.
Thank you very much.
Sure.
Thank you, Andrew.
Thank you.
My apologies, my app's not working. Oh, it's time for Dr. Adex Tadase from the Brigham and Women's Brigham and Women's Hospital here in Boston.
Okay, good morning. I'm going to present on a role of pharmacogenomics in cystic fibrosis patients who are already transplanted are on ATI therapy. No disclaimer or disclosure to show. I have no relationship. So the background, you heard a lot about the benefit of ATI therapy in patients with cystic fibrosis, and there is a lot of hesitancy to start patients who are already transplanted on ETI, and we wanted to look into this topic a little bit more closely. There is a lot of work done already. I think Dr. Ramos is here, who did actually one of the bigger studies on the benefit of ETI on patients who are already transplanted. It improves their overall health, improves diabetic control, improves their anemia. There is also less need for antibiotics. There is no benefit as far as BMI demonstrated from Dr. Ramos' study, but there is a question of whether a patient's graft ACR is going to be better or not. So I think the main sticking point as far as starting patients who are already transplanted for cystic fibrosis on ETI is like what's the issue with tacro. That's the main backbone of immunosuppression for tacrolimus is a main backbone of the immunosuppression and its relationship and interaction with ETI. There are also other couple of studies who showed either no difference or patients have like perceived feeling that there is no efficacy. But the main study I'm referring here is the Dr. Ramos study. So what's special about our study is we try to incorporate pharmacogenomics into patients' clinical care when we prescribe ETI on top of their immunosuppressive regimens. As you know, the ETI and tacrolimus are both metabolized by cytochrome 450, a special isoenzyme like cytochrome P3A, 4 and 5. So there is already guideline from pharmaceuticals, and there is also guideline from the CPIC guideline for medication dosing, just based on the type of genes or type of alleles they carry. And we classify patients into 5 groups. There are normal metabolizers, there are intermediate metabolizers, and there is poor metabolizers. Most of Caucasian patients, like around 85% of patients are poor metabolizers. So, like I said, the poor metabolizers are the predominant patient population. So there is already guidance that if a patient is a normal metabolizer or intermediate metabolizer, he can go up on the tacro dose in order to achieve therapeutic dose. And if the patient is on poor metabolizer, he can just go ahead with the standard recommended dose. So the study we did is like retrospective, electronic health record based retro cohort. We examined around 42 patients who have been on already transplanted on immunosuppression with tacro and on ETI. We and have undergone testing, pharmacogenomic testing. We found from 42 around 8 patients, and we're gonna talk about those 8 patients. The aim is we are thinking that doing a pharmacogenomics makes life easier for transplant physicians to determine the initial dose and monitoring of their tacro and adjustment of their medication just based on their metabolizer status. So we use a company that's OneOme. This is a company who does genetic tests. It's accredited by American Academy of Pathologists, and it's also recognized by American College of Physicians, but it's not FDA approved for clinical use. So patients are examined. The ETI was initiated between 2020 to 2022, and we followed their clinical parameters until July of this year. Criteria for inclusion is like anybody who's going to be on ETI and lung transplant recipients with F508 deletion. And the main indication when we review the chart from the patients is like extrapulmonary symptoms, all of them mostly like uncontrolled nasal sinus disease, and some of them with GI symptoms. That's the main indication. And we monitor their BMI, FEV1, symptoms, improvement, and the tacro level. So this is a little bit busy slide. I'm going to zoom into the slide and discuss our results. So the patient's age range between in the 30s to 60s. Most patients are females, a couple of males. They were able to maintain a BMI above 18, except one patient who had a lot of GI issue that that kept her BMI in the 16s. As you can see, we can't say anything about graft function just based on the FEV, but most of the patients have maintained their FEV1 more than 1.25, so except this patient. As far as they all have some variant of 508 deletion, and the comorbidity, almost all patients have sinus and nasal disease, and most have diabetes mellitus. During their course of follow-up, the ETI dosing was most patients have tolerated full dose. A couple of them required reduction of the ETI because they were on antifungal, another agent that makes up cytochrome 450. The patient had like cryptococcal meningitis and was required a few prolonged period of antifungal, and the second patient had ABPA and required some period of antifungal. That's why the patient was reduced on a half dose. The tacrolimus level, even if we are worried that patients who are on ETI will have like very wild swings of tacrolimus level, they were able to be maintained mostly within therapeutic goals. We estimated between 75 to 90% of their tacro readings were within normal level. As far as the pharmacogenomics, like we expected, most patients were poor metabolizers, and one was intermediate metabolizer. Otherwise, all of them were within a poor metabolizer group. This is one of like patients who were poor metabolizer in representation of their tacrolimus level. On the y-axis, you have the tacro level. On the x-axis, you have the timeline. Most patients were being maintained between 8 and 4, and actually most of them were out of transplant more than a year, and most of their readings, except 3 readings, were within therapeutic range. And this is the one that's very interesting. I mean, this is a patient who's intermediate metabolizer based on the pharmacogenomic test, and had a hard time maintaining his levels above 5, and actually switched to another agent for immunosuppression. And it was very helpful for the clinicians like to consider that the reason why they were not able to get the therapeutic level is probably because of it's way out of transplant 5 years. They even tried to achieve tacro level around 4, but it was still difficult, and a patient is switched to another agent for immunosuppression. So what can we say based on this small cohort? I mean, the limitation is our study is very small. There are only 8 patients out of 42 who are being maintained on ETI and tacrolimus, and at the same time had this pharmacogenomic test. But we believe there may be a utility of this testing in order to expand access for ETI in patients with cystic fibrosis. And the second thing is it's possible to maintain both tacrolimus level at the same time maintain the benefit of ETI in lung transplant patients with cystic fibrosis. And we need to pay attention to patients who have an intermediate metabolizing and a normal metabolizing state based on the pharmacogenomics, because you may have to go up on the dose of their tacro. The other thing is, I mean, we have seen the patients visit to ENT and visit to those patients who have like diabetes, 6 out of 8, their visit to endocrinology. All of them definitely benefited from the ETI initiation, and they have an excellent control on their sinus and nasal symptoms, and at the same time a better control of their diabetes. So, so we may be able to expand access based on this strategy. The future for us is like we're gonna expand this study to include almost all of our SAFE registry from Boston Children and Brigham. And also we're gonna also try to see if there is another agency or another company that's gonna give us like a test based on like for this metabolizing status, if it's more standardized, FDA approved. And another thing we may have to look at is like graft function and looking at the transbronchial biopsy and graft function based on like after patients are initiated on ETI. I would like to thank Dr. Kennedy, who actually brought this idea of investigating this, and Dr. Oler has been very supportive. Dr. Gay is my program director, and I will welcome your questions now.
Outstanding work. If anybody has any questions, please come up. Fabulous work. We're starting to get into more of this ourselves here at Cincinnati Children's. Question for you, has this changed your practice? Has it led you to anything of how you're changing or managing the immunosuppression?
Yeah, I would say so. I think the transplant pulmonologists are aware of this result and it's available in the patient chart. Actually, surprisingly, almost all of the testing has no additional cost to patients. For some reason, it's well covered by the insurance. And that's, I think, particularly in switching a patient from one immunosuppression from tacrolimus-based immunosuppression to another one was, I would say, is something that probably has changed some clinical practice in our transplant group.
This is what I figured. What other immunosuppression protocols are you using, or are you aware of them? Are you transitioning to cyclosporin, or is there a different immunosuppression protocol?
Yeah, the problem is cyclosporin is also metabolized by the same cytochrome enzyme, and I think they have attempted to switch to long-acting CNI, everolimus. That's what they did.
Yeah, no, I mean, I think we started this trial in 2020, 2021. There were a lot of things going on then. First of all, we thought ETI may have bigger benefits on BMI, on blood sugar control, on things like reflux, which might lead to less rejection.
Yep.
But there was a lot of fear about, tacrotoxicity, drug-drug interactions driving up our levels. I think using this data helped us lower some of those fears. Initially, when we set up this trial, we were doing serum CNI levels weekly. We had the patients coming in all the time. We're kind of doing like goal-directed therapy. I mean, we would give you the drug when we saw the level.
That's generally the goal, correct, is to goal-directed therapy, so to speak.
Yeah, exactly.
And what you're working towards, too.
Yeah. So I think that was the biggest thing. It lowered some of the barriers and some of the fears about toxic CNI levels. And I think all of our patients that we've been able to start on it, except for one, have maintained dosing. And initially, we'd hope to include things like a formal SNOT registry looking at the pulmonary disease, and some of that fell aside with our pandemic experience. But anecdotally, we're having good results in these patients.
Thank you. We do have an audience question. Thank you for this, Nora Burtis. It's a question I was wondering as well. Does your team preemptively adjust tacrolimus dosing when you start ETI? Do you actually preemptively modify it before you start the ETI?
I think the initiation was independent of the pharmacogenomic test, but that's the hope in the future. We may be able to upfront just determine the dose based on the patient's comorbidity and the pharmacogenomic test result.
The next question to answer is how to modify the preemptively. Is basically what your goal is. Is that correct?
Yeah. Yeah, I mean, there is already recommendation from this GSK, and there's also a recommendation from CPIC guideline about how to dose patients with different, these 5 classes of cytochrome profile. You usually give them a standard dose only if they are a poor metabolizer. Otherwise, it should be modified by 25% to the next class. But I mean, I work in a transplant clinic, and there is also several other factors we need to consider when we determine the initial dose.
Thank you for an excellent talk.
Thank you.
I think we're at our final speaker. Dr. Asim Ziadi at Cincinnati Children's will take us home. He will talk about individualized lung transplant care, looking at biomarkers for chronic lung allograft dysfunction.
Thanks, everybody, for showing up. I'm in the predicament of being between you and your lunch, which can be pretty dangerous, but I'll try to make this...
We have hungry eyes in the audience.
Yeah. Try to make this as painless as possible, hopefully. We'll see. So I'd like to thank the moderators, obviously, for inviting us to show this work. We've been working with a team at Children's that includes Don, and actually a name that should be on this slide is Andrew's name. Andrew's not involved directly with the work I'm going to show you today, Andrew Potter, who presented earlier today. But he is working on a project with us that's pretty exciting of connecting what he sees in ACR and what we see in CLAD, and we're trying to build a bridge between the two to try to understand how the disease progresses. So it's been a whirlwind. It's for the last couple of years. I first sat down with Don to talk to him about what he does and what I do. I have a background in redox-mediated inflammation, in lung disease, and in gene therapy, and in biomarkers. And Don obviously is the transplanter. And when we first met and just started to chat, we got to talking about the problems in transplant, and CLAD was one of the ones that we sort of honed in on, where we could make a difference. So I'll credit the, I'll come back to the acknowledgements later on, but I want to point out that the work I'm going to show you today is an even split between analyses that were sort of deep dive analyses that Valentina Raffato had done. And then Emily ran all the mass spec work and has generated a lot of the data analysis I'm going to show you also in the middle of the talk. But everybody made a great contribution. So disclosures, myself, Don, and Emily are, who are authors on this poster, have an invention disclosure related to this work. So when as I was mentioning to you, when I sat down and talked to Don about this, and this sort of what was a side hustle on the horizon for me talking to Don. Don is such a beautiful person to collaborate with, and just so fun, ideal really for a PhD that wants to do translational work like ourselves. We sat down and talked about CLAD and its definition, and the clinical definition is up there, and I'm sure most of this audience is familiar with it, but it involves 3 months of lung function declines that are consistent and not attributable to other and not attributable to any other clinical phenomena that may be resulting in the lung function in the pulmonary function testing being decreased. In CLAD is being defined now as being split between bronchiolitis obliterans, which can develop in about 10% of these folks, and I'll actually pull this up here for a BOS diagnosis. So about 10% of people with lung transplants will have to deal with CLAD, especially in the first 4 years of post-transplant. Mainly the diagnosis is made through spirometry imaging and PATH, PATH being the most decisive method of using, but imaging and spirometry is also used. And we chose to focus on BOS when we started, but of course there is the restrictive allograft syndrome that can occur in CLAD as well, and then there's mixed as well, which we're just starting to get into, but I'll just show you the work that we've done on BOS. So when Don and I sat down and talked about what could we do, we had this platform in the laboratory where we can do proteomics and do deep dive proteomics. So it's not run-of-the-mill proteomics you can get at like a service center, but we can do this high fractionation deep dive proteomics that can tell you information about tens of thousands of proteins potentially. I mean, the average analysis that we do captures maybe 18 to 20,000 proteins that we can do in a sample, protein isoforms, I should say, which is quite impressive. It takes a lot of time to do it. Emily has to work overtime to fractionate the samples and get all this information about these proteins, but it's basically like running 20,000 ELISAs on a single sample, and that could be bowel, that could be a piece of tissue, that could be cells from the blood, or it could be plasma or serum. And so we got together with Nirmal Sharma at the Brigham, who had some adult samples that he had banked, and this is the demographics for the folks that we started. So this is sort of a talk about trying to personalize this for specific subjects and patients dealing with CLAD. But we started with looking at what happens at the population level and whether we could define how CLAD is developing in these folks and sort of point it out and maybe try to therapeutically prevent it or stop it. And so I just really quickly go through their age matched. The main indications, underlying indications is IPF for these. These are adults again. They're well matched for sex and age, and then you can see that the lung function is a little bit on the low side for the folks that have bronchiolitis obliterans. And then there are the grades. And so in terms of methodology, and we can get into the details of this if you'd like, but in the questions, but what I'm going to talk to you about today is whole bowel. There is some data that we have on the two patients that I'm going to talk to you about where we did N of 1 studies on. Those were blood analyses, and we do a lot of blood analyses as well, but I'm not going to show you the population blood analyses that we've done. But when we looked, when we started, we took bronchoalveolar lavage, we fractionated it on gels, I should say, we as in Emily, and you get this fractionation that she fractionates them by gel chromatography, and then we fractionate them on columns before they go onto the mass spec, and then we can excise these or isolate these proteins and digest them and prepare them for mass spectrometry. And that allows us to really look at a lot of different proteins at the same time. So that's what the mass spectrometer looks like. It's sort of Emily's third child. She has to take care of it all the time. And we use label-free quantitation. There is an approach where you can label your proteins and compare it so you can get actual true quantitation of what's happening with the proteins. But if you use label-free, you can do semi-quantitative ratiometric quantitation, which works just fine, and it's actually a lot less limiting and less expensive than doing labeled quantitation. And it's not limited, so you could look at many more proteins. And we used the run-of-the-mill analyses using Proteome Discoverer and rank proteins in terms of differences by their p-value. And then one extra step that we usually do is run no decoy or reverse data-based decoy analyses of the protein differences that we see in CLAD or non-CLAD or BOS or non-BOS and look at the pathways that are involved. And I'm going to show you a lot of that. You're going to see proteins in the pathways I'm going to show you. But the pathways are what tell us what to go after in terms of a therapy. The highlight, I think, of the talk of the specific data I'm going to show you, it highlights basically three main signaling cascades or networks or pathways that may be interesting. One is inflammation, and you can see IL-6 out there is highlighted, but there's other pathway, there's other signaling inflammation that's also implicated. You can see the complement is activated there as well, so it's a different arm of inflammation. And it's very interesting because the mass spec detects the complement in BOS at the level of deposition and not just circulating complement levels or C3, C5 levels. And so it may actually be missed in a clinical lab test while you still have this non-canonical complement activation that's taking place in BOS. And there's also this proteolysis defect that we see. It may not be a defect, it may be a system response to increased protease activity, serine protease activity, but the serine protease inhibitors, things like alpha-1 antitrypsin or alpha-2 microglobulin, proteins that are very important in sort of shutting off these heavies that we have in our bodies to take care of bad things, are not behaving the right way. And so when that happens, you really become susceptible to these proteases, having their way with you, and that's not a good thing, especially when you're talking about lung disease where there can be a lot of injury and damage and remodeling. And that probably is what initiates, antibody-mediated rejection is this kind of innate inflammatory process that simmers, and then it basically triggers immunity, recruitment of T and B cells, and triggers more AMR or antibody-based rejection down the line. But we're not sure, we're still trying to flush all of that. And there's also some ECM remodeling that it's sort of trending but not statistically significant. So I'm going to highlight the complement because the first patient I'm going to show you, the first subject I'm going to show you, the first one I showed you there with networks, these are what people call GO processes. They're basically gene ontology processes that are defined by scientists out there as being that lump proteins into canonical pathways that we can talk about in terms of physiology and so on. So you can see that there's acute phase responses are pretty much inflammation. And again, you see, but maybe not complement mediated inflammation, but again, you can see complement showing up here in 2 spots. Proteolysis is still an issue here in this data set. And then you also see some coagulopathy hits down here, which are pretty interesting. So fibrinolysis like that down there is interesting, and I'm going to show you in a little bit how it all sort of connects. So just for the first subject, who was actually a lovely young lady with CF, that was being seen and had presented with an acute presentation and become ventilated, and was a complex case. It was not clear what was going on with her, and what we did was we had collected samples before this event had taken place, because at Children's, anytime these patients, the patients show up at the hospital for regular visits or surveillance bronchoscopies, we collect samples and we bank them. And that's one of the things we've been doing for the last couple of years since Don and I started working together. And what we found again is what we had seen in the population analysis of this non-classical complement activation going on that was not actually captured in clinical labs. And so based on this and some further clinical labs that Don did to actually track down if there was deposition that can be detected, and at this point the patient was intubated, and Don can tell you more about the case. This is what her baseline looked like, and this is what she looked like at the time of intubation with a worsening left lung there, as you can see. And then 24 hours after after Don gave her eculizumab, which is a C5 inhibitor, based on what we had done with the proteomics, you can see that the left lung there was resolving, and she became extubated soon after. So that was the first case where we had actually taken something that we had done in the lab, and Emily and Matt are able to run these analyses within a couple of days. I mean, we can literally phenotype a person in a couple of days from head to toe, which is pretty cool thing to do, and be able to come back to the clinical side and say, hey, maybe look a little bit deeper for these specific things in your clinical labs, because typically you want your clinical labs to confirm something you find in a research lab before you go and do anything to one of your patients. Just digging down a little bit deeper and giving you guys some proteins for those of you in the audience that may be interested in the specific proteins that are involved. These protein networks that change, you can sort of connect them together. So there's pathway analysis software that are out there that use, they're not that smart. I mean, they look smart because they look complicated, but they're actually pretty dumb network builders. They look at where 2 proteins exist together in a publication and say there's an arrow between this and this. But they don't really dig deep and understand what the relationship really is. And so you do really need a human being doing this and thinking about this, not just somebody who plops it up and puts it on a screen and then you go jump into a patient. That's not something you want to do. But it does give you an idea of where to focus. And so one of the clear features that I mentioned to you before is that there is protease activity that appears to be off kilter, and this may be neutrophil-driven elastase. That is not something that shows up in our data set, but the inhibitors of neutrophil elastase do show up as misbehaving. Alpha-1 is up, A2M is up, alpha-2 macroglobulin is up, and typically when you see things going up, I mean, you can get two kind of conditions in a human being where something doesn't respond like it should, so it's down, or actually it's responding like it should and it's way up. And so when you see it way up, it's telling you that that pathway that it's responding to is way up, which is probably the case here. So this probably indicates that there is a plethora of elastase floating around in these folks that are developing CLAD. That ties into some inflammatory signaling that's very closely connected to blood clotting, which is very interesting. And so that translates into this coagulopathy we see. And it borderlines something that happens in bronchiolitis obliterans in bone marrow transplant patients called TMA, thrombotic microangiopathy, where you do see this coagulopathy coupled with this complement activation pathway. And it's probably similar to what happens with viral infections like COVID even. And then you have this other arm that has to do with T-cell activation that's also intimately tied to this pathway, and then inflammation, classical inflammation, and complement inflammation are also on the bottom end of this. And so you can see how connected this all is. And you can see that over here, JAK-STAT is one of the driving forces that sort of feeds this pathway. And so I'll just focus in on that real quick. So if you look at, these are some of the drivers of what can cause JAK-STAT activation. And JAK-STAT, I'll show you in a second what they do. There's a drug that can regulate those or inhibit those. It's called ruxolitinib. It's an anti-neoplastic drug that is used for leukemias and cancer therapies, is indicated for that. But I'll show you what JAK-STAT does in a second in just a summary slide. But what drives JAK-STAT activity is canonical type 1 and type 2 inflammatory signaling, but it can also respond to interferon signaling and responses to virus, as well as TGF-alpha and VEGF. And you can see that it talks to a litany of things that you would associate with lungs not being in good shape. So you have, cell adhesion, which is all about, and cytoskeletal reorganization, which is all about inflammatory cells getting into airways, and to do that, they have to change their cytoskeleton so they can squeeze through blood vessels and get into the airway and do their thing, so that when you see that being elevated, that typically means that the lung is getting all kinds of inflammatory cells coming in from the blood. There is suppression of apoptosis and increased cell proliferation, which is interesting, or changes in cell proliferation, which again indicates injury and survival mechanisms. Cell division and viral spread is represented. Antiviral defenses are upregulated. And all of them are tying back to this JAK-STAT pathway: T-cell activation, inhibition of tissue regeneration and remodeling, and modulation of inflammatory responses. So we honed in on JAK-STAT as a second sort of pathway. The first one we had done was the complement one. And in this young man, we had a subject that I'm going to show you in a second that had the signatures that we had seen in the cohort analysis that brought us to ruxolitinib. But ruxolitinib, as I mentioned, is an anti-neoplastic agent. That's what it's approved for. It's very hard to get it insurance covered for uses other than that, although Don's been really successful doing that lately. But I'm going to show you a subject that had bone marrow transplant previously, and so the use of ruxolitinib was allowed there for insurance purposes. But what ruxolitinib does is it inhibits the JAK-STAT machinery, which you see right here, which assemble right around cytokine receptors in cells. And so some of the cytokine receptors in our cells that we have are tyrosine kinases that dimerize around their cognate ligands. And you can sort of see that across the membrane there up here. And when they do that, then they phosphorylate each other, the tails of themselves on the cytoplasmic side, and that makes JAK-STAT sort of dock onto them, get activated, and then it becomes a transcription factor then that can go into the nucleus, translocate to the nucleus, and activate the expression of all of these survival genes and so on, pro-inflammatory genes. So ruxolitinib will inhibit this process, and that's sort of the mechanism of the drug. There's some adverse effects and of note, and of course this is something somebody will probably ask a question about, what happens with viral infections and neutropenia, which have to be monitored after you give this drug. This is the subject that I was telling you about that had a transplant in 2018, and you can follow the course of FEV1 here down at the bottom. A few months after transplant, the FEV1 was at 100%. By October 2021, so 3 years after transplant, his FEV1 had gone down to 65%, and by December of that year, it had gone down to 57% when the diagnosis for CLAD was made for BOS diagnosis, and at that time, corticosteroids were given as well as ruxolitinib was initiated. And so, just to give you an idea of the trend. What happened with his lung function after he went on ruxolitinib. So this was the course beforehand. This was the place where the diagnosis was made, and then the ruxolitinib initiation here. Of course, there's some other things overlaying this, like the steroid treatment. But the patient basically remained free of cytopenia and continued to test positive for respiratory viruses via nasal swab after initiation of ruxolitinib, but they had had viral infections beforehand, so there was not an appreciable or significant increase in the viral infections afterwards. But this is where he is now after 2 years of initiating ruxolitinib, and basically avoided CLAD, avoided losing the lung. So in summary and conclusion, I think we're trying to build, and again, this has really been exciting because Don is truly like the. I think everyone loves working with Don, but as a PhD who likes to do translational work, I can tell you it can be really challenging sometimes to work with people that do science as like think of it as a hobby or something that they just want to check off a box on the resume or something. Don is not. I mean, he's really, really interested in changing things and trying to figure things out, and you can really only do that by looking at molecules, and so. It's really exciting to work with them, and we're trying to sort of build this program around the patient to connect the lung transplant team, the bone marrow transplant team where I work in bone marrow transplant at Children's, and then connect it to research and also infectious disease. I think in conclusion, I just say that proteomic, and I think other analysis too, I mean, I'm sort of just harping on proteomics, but can give you a lot of information on subjects that you may miss in clinical labs. I think the collaboration between the research and clinical sides are very good and important, and I think we're currently now working, amongst other things. I mean, one of the coolest things we're working on is this ACR connection to CLAD that we're doing with Andrew, that Andrew and Emily will be working on, but we're also working on this number is actually around 18 now, other potential therapies on top of ruxolitinib, and trying to unpack how to determine when people should go on these drugs and how responsive they're going to be to it. Because not everybody that gets ruxolitinib, you don't stop CLAD in everybody that gets it, only certain subjects. So one of the other projects that sort of popped up now is to try to figure out who is the best subject for ruxolitinib, who's the best subject for something like eculizumab, and then we've got a panoply of other drugs that are already actually FDA approved, but it can be repurposed to try to get at this problem. So I'll stop here and just recognize the people that did the work. Valentina did the analyses on the ruxolitinib and the JAK-STAT that I showed you. Emily did the mass spec analyses and some of the pathways with the hits on complement activation and inflammation that I showed you. Matt has done the N of 1 studies in subjects. And Runima was in the lab for a year that helped with all of these analyses. And of course, our collaborators, Don, Stephanie is a PharmD that actually works very close as part of that team that I showed you, Nirmal at Boston, at the Brigham, and Stella Davies, who's my boss at bone marrow transplant. She's been very supportive of this work. So the work's funded by the NIH and then also by the CF Foundation for a grant that we got. Thanks.
Great talk.
Hey, thank you.
What similarities do you think you're going to see as far as sort of biologic, maybe inflammation, in particular between the bone marrow transplant clad and then the lung transplant clad?
That's
Thanks.
a great question. So actually, the upcoming lung transplant meeting, which is going to be in Boston in April, I don't think it's this convention center though. I think it's the one in Prudential, but I could be wrong. We submitted a symposium to deal with that because what we've done bone marrow transplant BOSS, and we find a lot of overlap actually between bone marrow transplant BOSS and lung transplant BOSS. The interesting thing is that not everything between the adult cohort that I showed you main highlights today from the adult cohort that translated into these pediatric patients that I showed you at the end of the talk. Not everything that happens in the adults happens in the pediatric population. But if you look at pediatric lung transplant and pediatric BMT, they're very, very similar. And so I think there needs to be more attention paid to the pediatric populations is one of the points I want to make here also that I didn't make during the talk. Because while the adults can teach you something about the kids, there may be actually other things going on in the kids. But there's a lot of similarities between bosses and both sides. We're gonna hopefully come back and present about that or present it about it at the transplant meeting. So we can talk offline if you want about it. I can show you the data.
Do you think adults and children are different because of adults having so many comorbidities, or do you think it's something else?
So I think it's probably a culmination of it's probably a result of a bunch of different things, comorbidities, and some of these you can see the adults have underlying, COPD, IPF, so they may be smokers, there may be other things going on, and the damage that comes from that may not even be involved in the respiratory. But I think also your immunity is different when you're adult versus when you're a kid. So, and this, ultimately ends up being an immunity problem, even though most of what we see when we're looking at this is at the innate level, and we actually see a priming for the antibody-mediated responses. Even innate immunity is a little bit different in kids than it is in adults. And I think as you get older, your immunity becomes more trained, more vigilant, and kids may let things pass sometimes or may not be as primed to attack something and go crazy and create a cytokine storm. So I think that may be also where some of the differences will be. So.
All right. Well, if we have no more questions, we'll end there. I want to thank all the speakers. They did a fantastic job. And then our co-chair, Dylan. Thank you.